very kind, and it's been a great pleasure seeing all the presentations today. And I think I can summarize Dr. Hahn's introductions. I'm the old guy, so I kind of lived through a good portion of this, and so I'll try and, not all of it, some of the earlier stuff, but go through it. These are my disclosures. And basically, you're looking at AAAs as comes through. Most of them are found by an incidental finding. Again, being the old guy, I still say they should be found on physical exam, but I've had patients that come in and they say, well, every time I lay down in bed, I see my book bouncing up and down and didn't think that was normal. So, of course, someone got a CT and never laid hands on their belly. But I think physical exam is something you need to look at. Embolization is not frequent. And then, of course, the dreaded when they come in. Rupture, generally, as was pointed earlier, at Friday night at 3 o'clock in the morning. Once they go on to rupture, the mortality is between 50 and 80%. So where did this all come from and how we started thinking about managing it? Well, the earliest aneurysms were actually treated by ligation. And that was something we came in and more for peripheral arteries, they'd come in and ligate. But if you ligate the aorta in and of itself, that really the patients do not do well. And so that then said, well, let's try and slowly ligate the aorta. And so we came up with a bunch of devices that were implanted, wires, coils, and everything else, to try and induce a gentle, gradual thrombosis that could lead to exclusion of the aneurysm through thrombosis. And that, because of the high flow setting, didn't work very well either. And so this is something that probably would not get through our IRB now, but they then said, let's try and denature the protein in the blood around this area. And they actually started putting an electrical current through the wires coming out through little electrodes. And that, of course, didn't work very well either. So then they came back, and here's you can see where they've put massive amount of coils in there, and obviously it's a post-mortem exam, so this didn't work that well either. They said, well, if the problem is the aneurysm expanding, the bigger it gets, just like a balloon, the greater the risk of rupture. And so let's just wrap it like a girdle and prevent it from rupturing and kind of give an external support. And I know all the attendings in the room know, but some of the medical students may not know that actually Albert Einstein had his aneurysm wrapped, excuse me. And then unfortunately, after he had his surgery, he went on to rupture, and being the brilliant man he was and knew what, his probability to surviving, he said, no, just keep me comfortable, and he actually died of a ruptured aortic aneurysm after having it wrapped. Excision and grafting then came about, and that's where they actually came in, and originally they cut out the aneurysm and then tried to do an interposition graft. This was first done in 1951. So we're looking at really kind of a very short time period going back 70 years for when we actually did the very first was done in a dog and then into humans. And this was done in Paris by Du Bois. Then we went to exclude and bypass around it. If you're from Albany area, I think they still try and do that. But Voorhees showed that in 1952. Again, starting out with going to a non-homograft. The first ones were done with homograft. Then he came in with a nylon cloth, did that in the dog, and then finally in 54. DeBakey, I think we all know the story of DeBakey going and actually using his wife's sewing machine to create some of his grafts and having them sterilized and ironing them out on her ironing board before they were sterilized. So again, now we're in that 70-year window that really kind of has changed how we manage all these diseases. Everything's better with a laparoscope. We came in and actually were part of this when I was in Chicago of trying to do laparoscopic aortic surgery. And it did work. It only took 4 or 6 hours to do. And you end up, by the time you're done, making a little bigger incisions to try and get it done. But that was also about the same time that the endovascular era came. And once we really started seeing that the endovascular era was going to take hold, then we kind of abandoned laparoscopic surgery to a greater extent. And now we go on. Then we tried to, once we had success with EVAR, we started saying, what else can we do? And then thoracic endografts came about. And then debranching procedures before we had the fenestrated and branch grafts that was so nicely discussed earlier today, and laser fenestration and then all this, would actually come into a combination of open surgical procedure and then endografts to help decrease the overall mortality and morbidity of these procedures. And, I found that, by the time you went out and did a mesenteric renal celiac bypass, and then did your endograft, was about the same morbidity as doing an open repair. But they're still with patients, especially with pulmonary comorbidities, that would consider debranching procedures. And then it was nicely shown earlier today, snorkels, chimneys, sandwiches, and then finally fenestrated branch graft. So that's kind of how we're evolving now through the history of where we come from aneurysm repair. This, for those of you that know, this is a open repair. I say that in a hushed voice because this is how we used to do it. And when I was starting out as an attending, this is the only way we fixed aneurysms. We didn't have EVAR, we didn't have anything else. So this was the classic proximal distal control, great operation. And quite candidly, I think Dan really wanted me to give more of the behind the story. When we first started getting EVARs out, it was definitely a four-letter word. And there was a lot of work from the more senior people in the SVS that was really putting down the enthusiasm that we had for proceeding into endovascular grafting. And as we see still going on, most of the early EVARs were done on clinical trials, so it wasn't available to everyone as we went through, and so it was very limiting in that regard. If you look kind of going back through some of the early EVARs, many of us were doing back table mod, creating our own endovascular grafts as we did it. And that was, again, kind of hushed up and really didn't have a good thing for saying, this is what we're doing here. You had to do it in special cases. The other thing that was also said a lot, why we didn't want to do EVAR, and they said the risk of leakage and the endo leaks and everything else that we see, was that once you do an open repair, they're fixed forever and you don't have to worry about it. And that's not true either. And if you look at Johnson's work in the Canadian Registry, and this was early on, and I'm trying to go along with what the information was coming out around the time, we saw that there were significant potential complications from cardiac events, pulmonary, renal failure, stroke, as well as GI issues that really put in up to 15% risk of complications of morbidity associated with open repair. And then we go into more maximally invasive surgeries, go in the chest and abdomen, and that even had a greater risk. I remember, again, historically, I had a patient, I did an open thoracoabdominal aneurysm repair, and I thought it went exceptionally well. The patient did well. They were in the hospital about 7 days, went to rehab, had no pulmonary problems, had no renal problems, no paraplegia, and I thought this was great, and the guy must love me. And so he came back, and finally, I saw him multiple times in follow-up, came back at 6 months, and he said, well, I finally stopped hating you, just from the morbidity of healing from that big open surgery. And that was very impactful to me to really say I need to be moving more to the endovascular era. Again, this is, the open exposure for a thoracoabdominal aneurysm, diaphragms taken down, and really it's a major, major surgery when you do these. So now let's go how we evolved in Dr. Perotti. Dr. Perotti first came in and presented this, as was mentioned, it was rejected, but originally presented in 1991 with the Perotti endograft. And basically it was a Palmaz balloon expandable stent, as you see here in B, that he just sewed to a Dacron graft. Originally, he only put at one end, he said that the transluminal forces would seal distally, and he didn't put one at the distal end. That didn't work, and so he then came back and said, okay, he's going to put aortic Palmaz stents at both the proximal and distal ends of the graft. And that was the first very complicated EVAR, was just 2 Palmaz stents and a Dacron graft. Then they moved on to try grafts for thoracoabdominals. Dr. Tudor was one of the first in 2001, and that certainly showed a significant improvement in blood loss, length of stay, and morbidity and mortality. This is, again, everyone does theirs percutaneously now, but we always started with open cut downs and then came in, and this was an old anerex graft that we used repairing an aortic aneurysm. You had to have a good long neck as well as good iliac landing zones, not too much tortuosity, but still it certainly opened the era for as we came in and started doing these procedures. On average, they were 22 French devices for the ipsilateral side. But it certainly got us started. And then we came out and we started looking, and this is all the data kind of showing that there's a improvement with mortality as you go out at least to 3 years. This is Schermerhorn's work, and we reproduced this work at Columbia with Dr. Craig Kent, and really kind of showed there's a distinct advantage as you move forward with endo over open repair going out to 3 years. Then you go down, and then now if you look at some of the DREAM trials and EVAR trials, what they found is that as you carry out further in looking at this, if you go out 6 to 8 years, there's actually showing an improvement in survival in those patients that have open repair over EVAR. So again, then we are seeing some saying we may need to go back a little bit as we look at this. The problem is, a lot of people say, well, we can do this open repair, and like, no, I want EVAR. So no one wants to have the big surgeries anymore as we go through it. And this again shows that the improvement in survival as you went out to that 7 to 8 year period for open repair. Obviously, the dip that we saw earlier in the early period, but then as they go out long term, if they survived, they have a better chance of surviving long term. And this again further reinforces for complications and everything else associated with that, again showing that there is a long-term advantage for open repair. So let's go through, and it was kind of interesting because I was talking to some of the medical students, and they're like, well, you've always had thoracic grafts and EVARs and everything else, and it seemed like it was just assumed that we've always had this. Well, these are I'm going to go over the first 3 grafts, and it was kind of interesting because how we go through the regulatory process, how we look at this. The first ones I'm going to touch on, it was the aortic graft. And this was a graft, really, and this is again going and comparing it to the Proteus graft. But the aortic graft had no fixation. It had an outside wire form PET lining, and it was a graft that had one long ipsilateral limb and a short contralateral limb, and then they had a docking station of the modularity as you built your components down. And generally, this was something that they modeled this a lot from what we did with the open aortic surgery. And so back in the good old days when we did open, we'd use an 18, 20, or 22 millimeter graft. I think the biggest graft we had, Dacron we have, was 24. And so when they first came out with the aortic grafts, the biggest graft we had was 28 millimeters. How often do you use a 28 millimeter or less aortic graft nowadays? Not that often. Most of the time you're going to be using it. So we already started with grafts that were much smaller in diameter than what we normally would use. They had no fixation, so we did have one issue where, and you had to use many times multiple modular connections to build down, so they become 4 and 5 piece kits, cases, as you had to put a cuff proximally, cuff distally as you build it. But we certainly had a lot of flexibility, and we used a lot of these grafts. So how did it fail? We had wire form fractures associated over time. Grafts would migrate type 1A and 1B into leaks. We'd have modular disconnects with type 3 leaks. We had something called a soaker hose phenomenon where all those little sutures that were attached to the nitinol wire forms that have bleeding from it, and I actually explanted one, and you go in and literally the whole graft had these little jets coming out from every one of the little suture holes that was in it. And it also had a very short proximal main body. Again, trying to mimic how we did open surgery. We always had short and then long limbs. Well, that means if it had any migration, if it didn't migrate too far, you really couldn't do much to build up because none of the grafts would accommodate that short neck. And you're either doing an explant or then you're going back in and doing an AUI and a FEM-FEM. So it definitely we had a lot of cases implanted with it. A lot of patients did well, but there certainly was complications that came down the road. And eventually it was replaced with Endurant, which is a much more durable graft. And I don't think anyone's actively considering putting aortic in anymore, probably not even produce. This is the one that was most modeled after the standard open graft, and this was the Ancure device. It was a mild 27 French device, so you're somewhat limited there. And really, unlike the aortic graft, it actually did have active fixation at the top and the bottom, but it had no longitudinal support down throughout its entire length. And you had little markers as you came down so you could see it. And most people, they saw an aortic graft on CT, they wouldn't know what it is because all you see is little markers coming down in the proximal distal fixation. You had about 1 centimeter of open area here on the contralateral side, but they all were pretty much the same length. You'd have some difference of diameter and iliac limb size, but you really couldn't change the lengths of the grafts or anything else with it. And so besides being 27 French, and that's where we really started seeing arteries on a stick. You could put that 27 French sheath come out, and you bring out the sheath at the end of the case and it has part of the artery still on it. So that was a problem. And then if you came back in, it was also a single body, so you had to worry about wire wrap as you tried to get the device up. But it was considered to be open to similar to conventional repair. What we also saw with that is that iliac rupture, I mentioned, wire wrap, it would kink because these are unsupported. And if you put it into an aneurysm sac and the aneurysm sac starts shrinking, the graft has to go somewhere and it would kink. And we had a lot of issues with graft thrombosis. By the time we were getting further down with familiarity with, we were relining both limbs with wall stents. Just to give them some longitudinal support there as it came through. It did have a little bit longer body so you could move up. The fixation did work well. I didn't see a lot of migration associated with this, but there was a lot of issue with having the kinking in the fabric. And the biggest issue is also there's a large bullet nose cone for the device. And so you go and deploy the device, and you try and take out the delivery system, and that nose cone would get stuck. And you're like, okay, now here I got the graft half in, the graft's deployed and the delivery system's half out, can't come out. And guiding people came out and said, well, all you have to do is you have to break the device, and then you come up and feed a balloon up along the wires, and you could blow the balloon up and just kind of follow the balloon down as you brought the nose cone down. And so we became very good at breaking the device, and it seemed, second nature. Oh, it's stuck, and we'll break the device, get a balloon up, blah, blah, blah. Fixed it. Again, I questioned, the FDA. They came in and said, it's not in your IFU that you can break the device. And somehow just using the term breaking the device, they didn't really agree with. And so they did a full investigation, and they hit Guyton with a $92 million fine. And that's back when $92 million really was a lot of money. And put them out of business. And that was the end of the Ancure graft. So next one came out that was out near the same time was the Gore excluder graft. And this did not have suprarenal fixation. It just had small little hooks at the top, as it still does. One long limb, one short limb, and then you can have modular components coming down. They've expanded now to have branch components going into the iliacs. And it's a good way of trying to customize for your grafts coming down, but you really don't have good active fixation, especially none going above the renals. The failure mode was a hygroma. And what it was, because of the porosity of the PTFE, especially if someone flushed it with hep saline as they're prepping it, that saline would go into the nodes of the fibers of the PTFE, and the graft would weep, and then you'd get this transudate coming through, and we see all these aneurysms getting bigger. And when you actually went in to explant them, it was just this kind of gelatinous material, was non-blood containing. And they did go back and they changed the porosity of their PTFE fabric, and that has not been a problem. And this is really, of the first three, the only one that's really come into still being used today. So all the earlier grafts that we kind of talked about and used have found they failed, and we've had to come back with new iterations of them to make them last. And again, these are kind of the people that failed, and we'll kind of go through some of these as you go through. But most of the grafts that came out when I was just coming out in the mid-'90s have failed and are no longer with us. So I kind of made a quick table of looking at all the grafts coming out. So, we've got Endurant and we've got Excluder, or the grafts that really have survived the test of time. All the other ones are gone. And so Aptus, and I sat on the DSMB for this. It was an idea where you actually had the screws that are still out there, but the whole system was built where you'd have these fixation screws and then a Dacron graft coming down. The problem is the mandrel they used to make the Dacron graft, the iliac limbs, was they weren't following consistently, and they had some that were smaller than 7 millimeters in diameter, and they had a significant thromboembolic event associated with the use of the graft. They're having graft thrombosis, embolization, going up to about 45%. And that caused for the failure of the graft. And eventually, the fixation device, the Aptus screws, were spun off as a separate structure, and they're currently available, but the actual graft itself is not available. Similarly, Zenith LP came out, and this was the same thing. Had small iliac limbs, were used in small, mainly women, small patients with small iliacs, and they really weren't ballooning the iliacs that much, and they also had thromboembolic events due to the small iliacs, and they never came to market. The PowerLink, the AFX graft, it was based on, originally it wasn't designed or marketed for anatomic fixation. That came about as they started having more experience with it. But it certainly has been issues with trouble passing through the graft because the PTFE is on the outside and the wire forms on the inside. But more to the crotch leaks that we've talked about, it would actually wear a hole in the graft just at the bifurcation, leading to type 3 endoleak, requiring them all all to be relined, and then you're dealing with wire forms and all that to control it. So I think it's probably going to have a greater use for occlusive disease than actually aneurysmal disease. The iliac branch, this was a second branch device that was really coming out in study before the Gore iliac branch, but they had problems with their modular bridging stent. It actually broke. For some reason, and I don't see why they had that much mobility or anything in the iliac system, but they had significant instances of fracture of that, and that was over, well, so it's 15 years ago, and they still haven't got the product to market yet. So that's been a significant issue. Stentor never even got to the U.S. It was in Europe, and they had fabric tears and issues. P-branch actually went through clinical trials. It's a graft that was designed to have pivot grafts for a lot of the flexibility we've talked about needing for the renals, especially that upgoing renal. But they had so much manufacturing issues, even though they had a very good clinical trial with good results, they have not yet bring it to market. I see no evidence that they're going to try and bring it to market, despite completing the trials. Nelix is a balloon. I'll show a picture in just a second. It's the endo bag, we call it, where the grafts would actually be filled with a polymer in the bag itself. So it should really eliminate type 2 endoleaks and fixation, but they had significant issues with the type 1A endoleaks, and that led to the graft being taken off the market. Chivas was a proximal extension of that, and that was a complex trial enrollment. We were one of the leading enrollers in the trial, but they just couldn't get enrollment, and they stopped enrollment with that, with the cessation of Nelix also. And then Ovation, the alpha graft now, they have a polymer-filled support for the Ovation graft, and they actually had the gap where the PTFE went up, where the rings were being connected. It would actually delaminate, so you'd get this kind of just wad of polymer within that, or it could actually rupture, and if the polymer extravasates into the aneurysm sac, it's basically a cardiogenic shock, and they arrest, and it's quite a thing, and I've had that happen to me. So that is some of the failure modes we've seen with some of the endografts out there. This is the Nelix graft I spoke about, and again, this is something where they really just use this to fill the sac with a polymer, and then they said you could have a no-neck aneurysm. That turned out not to be true, and they did end up with a lot of 1A endoleaks, which caused problems. So where are we going? I think the future is actually very bright of all the technology coming out. This is some of the things. TAMBI has completed its trial. It's going to be probably will go to panel. I haven't declared it yet, but as a new technology, I can't imagine not going to panel. But it'll give us a kind of off-the-shelf 4-vessel graft for managing thoracoabdominals. Obviously, we get in the arch. We see different types of endografts. We have the endospan. We've got the TBE, which allows you to have one portal, and we've done our share of zone 0 TBEs, which I think certainly has worked very nicely, but does require carotid subclavian bypass. And then we have the volcanoes and everything else for preservation of the subclavian artery. The Gore tag graft has been further refined, so it's now conformable, so you can not have the bird's beaking, you can change the angle, and it deploys fully to 50%, so you don't have to worry about windsocking as it moves forward. And again, there's a listing of all the different other trials that are coming out, new fenestrated grafts coming forward, and I think this is all things that are going to make it much more available to us all as we move forward. So, I think this is something I'll touch very briefly for the trainees. We talked about the hybrid repair, and this is something where you can come in, and it's a 75-year-old woman I had early on. This was back in the late 90s. She had bad COPD, and she had presented with a painful thoracoabdominal aneurysm. So we came back in. And she had, again, the palpable pulse, and her aortic aneurysm was tender. This is her aortic aneurysm coming down. You can see she had a 7-centimeter aneurysm just at the level of the at the xiphoid, and coming down, and it really went down through the celiac and SMA and stopped just at the level of the renals. With or bad COPD, we really didn't feel comfortable trying to do a thoracoabdominal aneurysm repair on them, but we had to maintain perfusion. So what we did is we came in and did an angiogram and then did a bypass, basically coming up from the iliac to the celiac and the SMA, and we were able to do that just through a retroperitoneal exposure and a little 12 by 6 bifurcated graft, and then got her home in 10 days. Then we brought her back, and then we put a thoracic graft extending up beyond that area to seal the thoracic component of her aneurysm. So yes, it was a big operation. We didn't have to go in her chest, and that really was some of the early bridging technology of going from going from open surgery to EVAR, and then to hybrid grafts, and then finally with the fenestrated grafts and branch we're using now. In closing, I'd like to kind of go over, I looked in detail at the Medicare database, and we looked at those patients undergoing open and endo, and what are the advantages, and this is, again, over a 2-year period. But what we found in this database of open versus endo, we found that basically all major perioperative complications were about 50% less when you did endo versus open, with the exception of device malfunction. So, you know, if you had pulmonary dysfunction, renal dysfunction, MI, vascular, mesenteric ischemia, all is significantly less with endo. So I think we're on the right track here. I think the history has been very interesting of how we've gotten here, but I think you all will see a much more interesting and complex future as you move forward, as we get new and better devices. So I appreciate the opportunity to kind of share my historical review. I don't want to go over, but I could talk for many more hours on this, but it's been a great ride. I've been very lucky to kind of been right at the beginning of this and then live through all the change that we've seen, but I'm envious of you all as you see the new changes coming forward. So good luck, and go out there and do a great job with it. Thank you.